Thank you very much, Mr. Chairman. I would like to thank Dr. Sechkin here for the very kind invitation and for his hospitality during this meeting, a very interesting meeting with this focus on endometriosis in adolescents. My topic will be the clinical question whether early detection and treatment of adolescent endometriosis can actually prevent adult endometriosis. And I give this talk on behalf of two of my colleagues, one being Dr. Christa Meuleman, who just got a PhD, partly on studies in adolescent endometriosis, and she's the lead surgeon of our endometriosis research group, and Professor Hoppenbrouwers, who is actually professor in adolescent and child health at our university, and so we try to work together in this field of adolescent endometriosis. I work in Leuven University Hospitals, which is located in Belgium, a small country in the west of Europe, and our hospitals are actually one of the largest teaching hospitals, closely linked located to Brussels, and one of the oldest universities in Europe, founded in 1425. I want to go with you through four issues. What's the prevalence of endometriosis? What's the prevalence of pain complaints in adolescents? How can we detect early endometriosis? What are the tools, or which tools do we need to develop? And then finally the question, can early treatment indeed prevent adult endometriosis? We all know endometriosis, no need to repeat this information. It's a chronic inflammatory reaction related to ectopic endometrium, mostly located in the pelvis. And we can look at it as a disease which can be staged in various forms of severity, ASRM classification being the most used classification. And in terms of phenotypes, we can distinguish three, although they do not necessarily represent a different disease. They often coexist, but I think there is consensus that you can look at it from the peritoneal disease point of view, ovarian endometrioma, and then the deeply infiltrative endometriosis point of view. So let's start with the first question. What's the prevalence of endometriosis in adolescents? First, we need to know that all of the evidence here is obviously highly biased, because you only would know in adolescents who present for a clinical problem which requires laparoscopy. Taking into account that limitation, nevertheless, it's possible to do a systematic literature search, which we did for the last 30 years. Keywords: endometriosis, laparoscopy, adolescents, and chronic pelvic pain. This has now been submitted to Human Reproduction Update as an invited review. And we started with 1,014 studies, then 89 were left and read thoroughly, and only 15 really were studies that were selected because these were really studies looking at prevalence, not at just like documenting endometriosis in adolescents, but really as main primary outcome, the prevalence of endometriosis. The total number of patients covered, 893. And here are the results. The overall prevalence of endometriosis in adolescents with chronic pelvic pain and or dysmenorrhea, resistance to OCPs and NSAIDs, is 62%. If you look at the subpopulation of girls with chronic pelvic pain resistant to OCPs, it's as high as 75%, more or less similar as the ones with dysmenorrhea, and the ones who have chronic pelvic pain, just mentioned as a general problem, have a 49% prevalence. Surprisingly, the proportion of girls with moderate severe endometriosis is 1 in 3, 32%, which goes against our belief systems, but it's the data. So this is important. We need to be prepared, even in adolescents, to treat moderate to severe disease. And also here, the prevalence is higher, this time in the group with chronic pelvic pain, than in groups with chronic pelvic pain resistant to OCPs or with dysmenorrhea, which is again a bit strange, but these are the data. If we then look at how the moderate severe endometriosis is described in these girls, actually this was done in only 3 of the 15 studies. And it reads much like adult endometriosis. Rectal lesions, tubo-ovarian lesions, extensive disease on the peritoneum, ovaries, tubes and surrounding structures, rectovaginal, uterovesical, bowel and ureteric endometriosis. So it's all the same happening, at least in the proportion of adolescents. And that's why we need to reconsider how we look at adolescent endometriosis. It's not only about superficial lesions, peritoneal lesions. It can also be about ovarian endometriosis, ovarian cysts, and even deep endometriosis, which, as we've seen in the talk by the previous speaker, needs to be treated adequately, and which we also treat with laser surgery in our center. And this part of endometriosis is particularly challenging, as we all know. We completed a systematic review published earlier last year on the surgical treatment of deeply infiltrative endometriosis with colorectal involvement, 49 studies were reviewed, close to 4,000 patients, and whereas complications are reported fairly well in 94% of the studies, pain is reported in 2/3, but look at the underreporting regarding quality of life. Only 10% of studies, also using very various measuring and reporting modalities for symptomatic efficacy. Recurrence, 40%, fertility, less than 40%. So this is really a main problem in this field of our research, where we need to do much better in terms of prospective outcome studies with well-defined terms and definitions to do these studies. In our center, we use this laser approach, but more importantly, we use a multidisciplinary surgical approach with Dr. Meuleman as the lead surgeon in our group. And for specifically the surgery with deeply infiltrative endometriosis with colorectal extension, we believe it's very important to preserve as much as possible fertility in the future. So we published 2 retrospective case series and are now submitting a prospective controlled study in women with moderate severe endometriosis. And overall, the results, I will just focus on I think the most relevant things, is fertility is about 50% will become pregnant afterwards. And important is, of those who become pregnant, 40 to 60% actually achieve a spontaneous pregnancy, so don't need to go to IVF. And in this study, which is not yet published, we were able to show that in the group with moderate to severe endometriosis, if you have one group which receives a bowel resection for deeply infiltrative endometriosis and the other one doesn't receive a bowel resection because they don't have bowel endometriosis or the bowel endometriosis doesn't require bowel resection, actually for the fertility, it doesn't make a difference. 51% will become pregnant spontaneously, and 41% will become pregnant spontaneously of the 51% who achieve a pregnancy. And actually the ones who received a bowel resection, 58% became pregnant spontaneously, whereas the ones without bowel resection, 42%. Just showing that a bowel resection with the right indication doesn't necessarily impair natural fertility. And this is important, of course, for adults with endometriosis, but it's also relevant for teenagers with endometriosis, although obviously we don't see teenage endometriosis, this deep infiltrative endometriosis with colorectal extension so frequently, luckily so. But it can happen, as I showed in the previous slide. So we know the prevalence is high in selected populations. The next question is, what's the prevalence of the preceding problem, the pain? What's the prevalence of menstrual cycle-related pain problems in adolescents? And again, we did several studies. These have not yet been published. We looked at a very young group, 12-year-old girls in Flanders. And this is the first large population-based study on characteristics of menstrual cycle and related complaints in young teenage girls at or shortly after menarche. Close to 800 girls actually completed the questionnaire out of more than 5,000 that were part of this larger cohort study. We had developed a semi-structured questionnaire, and the results, that is out of 363 girls who actually had reached menarche at the age of 12, 42% reported painful menstruation. And the likelihood of this painful menstruation decreased approximately 50% for every year that the age at menarche increased. So later menarche seems to be protective against the development of dysmenorrhea and most likely also endometriosis. Painful menstruation was positively correlated with the duration of menstrual flow and the amount of blood loss, and there was a negative impact on social activities, generally speaking, in 1 in 4 girls. But if you select this group who actually reports painful menstruation, 41% had actually a negative effect of menstruation on social activities, more so than girls without painful menstruation. Then if you look in another group, now we'll move from 12-year-old girls to 13 to 16-year-old girls, and then from 17 to 21-year-old girls. This is a study done in the high schools in Leuven University neighborhood, and this is a study done in first-year university female students. And if you look here, the prevalence, menstrual pelvic pain reported often, mostly, or always 41%, 52%, and then plus also a visual analog score of 7 or more, which can be considered to be severe pain, 17, 16%, so overall comparable. Non-menstrual pelvic pain occurs less frequently. Impaired quality of life during menstruation, 12, 11%. Current use of hormonal contraception, 10% in the 13 to 60 years old, 66% in 17 to 21, logically speaking. But the indication to use hormonal contraception as an analgesic 40% in both groups. So 40% just uses these pills not for prevention of conception, but as an analgesic. And then the proportion of girls, young women with chronic pelvic pain refractory to OCPs or NSAIDs, 4 to 5%, and the combination of both, 1 to 3%. And I think this is the population we need to look at. 1 in 20, about 1 girl in every class, let's speak it that way, has a type of pain which is very likely to also be affected by endometriosis. So this is the group of girls we want to see in our clinics for early diagnosis and early treatment. This group not only presents with typical gynecological problems, but also with lower back pain, at least 1 urological symptom, at least 1 GI symptom. If you look at the group of adolescents here and the group of young women, overall you can say that the menstrual pain is much more pronounced than the non-menstrual pain, and that's true for both groups, for both lower back pain, urological symptoms, GI symptoms. And if you look at a trend, of course this is indirect, but if you look at a trend comparing how these symptoms actually evolve from adolescence to young adulthood, it seems like there is an increase in the lower back pain proportion during menstruation, 26%, 38%. Lower back pain reported not only as frequent but also as severe, 8% to 13%. Urological symptoms remain more or less the same, and the GI symptoms also seem to increase a little bit. Of course, this is indirect evidence, but it seems to imply a certain trend. Now let's move to the next question. How can we detect these pain problems at an early stage? And how can we improve timely referral to centers of expertise? We know quite a bit about this. We know, if you look at all the evidence which is available, specifically for adolescents, we know that there is a reduced risk of endometriosis if menarche is older than 14 years. We also know that there is increased risk for endometriosis compared to girls without endometriosis if there is frequent occurrence of early dysmenorrhea. And if you look at the specific risk profile for deeply infiltrative endometriosis, we know that those girls with a positive family history of endometriosis, with an increased frequency and duration of oral contraceptive use for severe primary dysmenorrhea, and those with increased frequency of school absenteeism during menstruation, that's all risk factors for endometriosis. So we need to use this information to develop a questionnaire which can be used in primary health care. And this is what we've been working on over the last few years. We first did a systematic review to identify those questionnaires that measure quality of life in women with girls with endo and chronic pelvic pain. And we selected the 3 best ones with the highest relevance, which is the EHP30, the questionnaire developed by Noham and Kelechi as a study by the World Endometriosis Research Foundation published in 2009, and then the questionnaire developed by Melissa Parker in Australia published in 2010. We believe those 3 are the best existing ones. And then we compared these questionnaires to 3 other existing questionnaires developed within our own university as part of past research. And then we compared them, the 3 international, the 3 national ones, and developed a new questionnaire based on the best elements of these questionnaires, plus the scientific evidence about risk factors. This is now being done, but it's not final yet, of course, because once you have a questionnaire, you need to validate. Just a questionnaire in itself is not necessarily added value. Unless you validate it, then it has scientific value. So this is the next thing we want to do. And then test it, integrate it into routine developmental surveillance practices of healthcare workers who take care of adolescent girls, and then see whether we really reach the target to have those girls with significant problems and actually can diagnose and treat them with endometriosis, for their endometriosis. And we believe strongly, and we published this paper a number of years ago together with Lone Hummelshoy on centers of expertise, at that time labeled centers of excellence, but expertise is a better word, that the concept should be that there is the woman or the girl and the gynecologist, and they are the decision-making team. And I think this applies to adult endometriosis, but even more so to adolescent endometriosis, because the girls still have everything ahead of them. Fertility, relationships, sexual activity, it all has to happen. So there's an enormous responsibility here to guide the girl, the woman, through the whole process of reproductive life with endometriosis and working together with a number of specialists as they are needed, with surgery, in my view, definitely as the primary method to diagnose and treat endometriosis. Then finally, if we then see endometriosis and we treat it, can we prevent adult endometriosis? The answer is simple: We do not know. Why do we not know? We haven't done the research. There is only 3 retrospective and 1 prospective case series published so far, to the best of my knowledge. And if you look at the overall picture here, the effect of surgery shows some improvement, but there is often recurrence or persistence of pain in this specific group. And about 50% require repeat surgery. And if you look at the effect of postoperative hormonal suppression, if we don't give it, progression has been reported. And if we give it, same problem. Persistence, recurrence of pain, significant side effects, leading to compliance problems. This is the overview. I briefly will go through these 4 studies together with you. First one is, if you do surgery and you don't give postoperative hormonal treatment, what happens? This is an interesting, although very small study, retrospective case series of 3 patients between 13 and 16 years. The presenting symptom was pelvic pain resistant to continuous oral contraceptives and painkillers. So they all received diagnostic operative laparoscopy, minimal endometriosis was found, and they didn't want to take the hormonal suppression therapy. Why? Because of side effects. Depression, irregular bleeding, fatigue. So they simply stopped it. Then they came back because the pain came back. Repeat laparoscopy for recurrence and worsening of pelvic pain showed progression to severe or mild endometriosis. So it was progression in all 3 of the patients, with actually 1 of them developing deeply infiltrative endometriosis, 1 an endometrioma, 1 diaphragmatic endometriosis. So, of course, very small series, but it suggests at least that if you don't give treatment in a selected group of girls, endometriosis may progress at a young age, which explains why moderate severe endometriosis indeed can be found in adolescents. Second study, retrospective case series in an interesting, fairly large group and highly selected group of 90 women with a median age of 17, not 7, and they were 17 years at the initial laparoscopy. So the inclusion criterion here is interesting. It's pain exacerbation after laparoscopy 1 during hormonal suppression. So they had an operative laparoscopy, they were receiving hormonal suppression, and under this hormonal suppression, they had pain exacerbation. And the first laparoscopy was actually done already for pelvic pain resistant to hormonal suppression and NSAIDs, and average minimal endometriosis was found, although there were some cases with moderate endometriosis as well, not really specifically mentioned in the paper how many. Then they received, after the first laparoscopy, postoperative hormonal suppression in all patients, 91% continuous oral contraception, 78% GnRH plus add-back, 12% progestin-only pills, and as you can see, many received a mixture of these types of treatment. Then those who were keeping the pain during this hormonal suppression got a second laparoscopy, and this is the 90 patients included. Median time, 29 months after the first laparoscopy, endostage, no change, improvement, or worsening, but the majority didn't have any change in the endometriosis stage, which is surprising. They were operated, they were under hormonal suppression, and still the endometriosis stage was not different from the initial stage at the first laparoscopy. So what's happening? Also in this study, out of these 90 women, another 33 received a third laparoscopy because the pain came back after the second one, median 27 months after the second laparoscopy, and again, endometriosis stage more or less the same, no change, improvement, or worsening. So it's puzzling because it shows whatever we do, it seems that there is a significant proportion of girls that cannot be helped properly with this approach. Then postoperative norethindrone acetate as an adjuvant to surgery. There is a paper in press in the Journal of Pediatric and Adolescent Gynecology showing that this can be useful for young women resistant to other medical treatment. This is again a retrospective case series, about 200 women, median 19 years. They all had minimal mild endometriosis. And this is a selective group again, retrospective, of patients who got an operation and then were treated with only norethindrone acetate after surgery. Why? Because they had persistent pain or bleeding on medication they used before the operation, being oral contraceptives, GnRH, or they had a contraindication for estradiol use. The result was significantly improved pain scores for all patients except those who received previously GnRH plus add-back, also significant improvement in bleeding scores, but 45% significant side effects. Weight gain, acne, mood lability, vasomotor instability. So whatever we give in terms of hormonal suppression, we need to also be very much aware of these side effects which lead to reduced compliance. We need better drugs, in other words, because what we have is simply not good enough. And then finally, the paper by my colleague, Dr. Jung, I think excellent work. It's the first prospective case series, and he should be congratulated for that effort, and we should follow that. It's a prospective case series of teenagers, 17 with 12 to 19 years, and they all had laparoscopically and histologically confirmed endometriosis. He performed operative laparoscopy for pain suspicious for endometriosis and found mostly minimal mild and some cases with moderate endometriosis. And then he looked at the rate of recurrence persistent endometriosis after this complete laparoscopic excision. Follow-up of median 23 months. And based on the information I read in the paper, 7 out of 17 received postoperative temporary hormonal suppression at their own initiative, but there was no sub-analysis of the group who did not. The 10 out of 17 who did not receive the hormone suppression was not analyzed separately. So it would be interesting to have the separate data analysis for that group. But in any case, if you look at the whole cohort of 17, pre-post comparison showed improvement for dysmenorrhea, dyschezia, painful bladder, quality of life, and other pain endpoints, but not for chronic pelvic pain or dyspareunia. And out of the 17, 47% required repeat surgery for persistent or recurrent pain. And at repeat surgery, half of them had some filmy adhesions, but no endometriosis were found, not macroscopically, and also not in the abnormal peritoneal areas that were resected at the repeat laparoscopy. They didn't contain any endometriosis. What does that mean? I think it means that this is a way to be followed. We need to document outcome, whatever we do in these girls, but we need to do it as structured as possible. And this is why we need electronic files to follow these patients longitudinally, lifetime essentially, as from the moment of their first diagnosis, with standardized questionnaires which are in development. We need to look at postoperative complications, at pain with FAST scores, which are done like every 6 months, every year, just as part of a follow-up system, quality of life, reintervention, recurrence rates, future fertility outcome. We need to report all of this. So, in conclusion, coming back to the 4 initial points I wanted to make, prevalence of endometriosis in adolescents with pelvic pain resistant to oral contraceptives or painkillers, 62%, 1/3 with moderate to severe endometriosis, which means if we do a laparoscopy, we have to be prepared that it may be more severe than minimal mild endometriosis. Second, prevalence of dysmenorrhea in adolescents, 42% at 13, 40% at 15 to 17 years, 52% in 18 to 19 years, associated with reduced quality of life and resistant to COX or NSAIDs in 4 to 5%, which is the target population we need to get in earlier. Early detection, we need to validate the questionnaires, and we need to use them then, again, in prospective research, in primary healthcare professional environments, in school doctors, to improve the timely referral to endometriosis centers of expertise. And finally, can early treatment of endometriosis, of adolescent endometriosis, prevent adult endometriosis? We don't know. We need to do the research, and we need to start with well-designed prospective case series, which everybody can do. It means that every patient who comes to you at age of 13, 14, 15 with laparoscopy-confirmed endometriosis, you follow her up, and you can do a patient preference study, whether you take or give her oral contraceptives or just spontaneous, it doesn't matter, but record it and publish it, because that's the information we need. And then once we have more information on that level, then we can start prospective controlled cohort studies where we compare different management, and ideally, of course, also in that population, randomized controlled trials. But in order to do so, we need to agree on terms and definitions in adult endometriosis, but also in adolescent endometriosis. We need to agree what is a complication, what is a recurrence, and many other things are so variable and subjective that everybody reports in a different way, and as long as we do that, we won't make any progress. And one way how we can achieve that is working on the new ICD-11 diagnostic codes with the WHO. I'm involved in the working group there, and I think if we can get global consensus on a number of terms and definitions in ICD-11, then worldwide we'll report the same thing, because one term will have the same definition everywhere. I would like finally to thank my colleagues at the Leuven University Center of Reproductive Medicine, and within which also the Leuven endometriosis research group is situated. And I would like to thank you for your attention. Thank you.